What is the single most important piece of research needed to improve the outlook for women with ovarian cancer? The most single important piece of research.
So I'm going to start by saying I can't answer that question because there isn't really one single area that needs to be improved. Obviously, if you wanted to start at the beginning, then it would be probably to detect ovarian cancer early enough to enable us to, cure the cancer. So the problem with ovarian cancer, as most of you know, is that 3/4 of women present with late-stage disease, and that means... Can you hear me now? Yeah. That means the outcome of ovarian cancer is very poor compared to, say, breast cancer, where 80% of women present with early-stage disease. So in breast cancer, we have screening. Screening works. And in ovarian cancer, we have so far not found that screening works. So I think if we could develop a screening test to develop ovarian cancer early, then that would be probably the single most important thing. However, that does not help women with ovarian cancer already. So when I was thinking about the question, I think probably another key area that we need to sort of develop and get better treatments for is for the women with platinum-resistant disease. So we know with ovarian cancer that most of the things I've talked about this morning are related to people who are sensitive to the platinums, and therefore they will be sensitive potentially to PARP inhibitors. And obviously so will the patients with BRCA mutation. So it's the other patients that I see day in, day out who say, yes, but what about me? Because I'm not sensitive to those drugs. So I think platinum-resistant disease or treatment beyond PARP inhibitors is the next sort of biggest challenge.
Thank you. So we've got early detection and platinum-resistant disease. Good start.
So I think Yvette's answered the question for all of us, really. It's going to make it really hard for us. I guess it's kind of building on everything that Yvette has said. And we know that PARPs work really well, and there's the sort of BRCA mutant group in whom they work very, very well. And I guess the next group I would really like to focus research on it is how we can extend the benefit of PARP inhibitors beyond that sort of BRCA mutant group. So we know there is a group beyond BRCA who are very platinum sensitive but don't carry the BRCA mutation, but we don't know exactly what the specifics of that group and how we identify them other than with platinum sensitivity. And then there's a group in whom PARP may be slightly less effective, but if we combined it with other drugs, it might become much more effective. So we might be able to combine it with an immune therapy or an anti-blood vessel drug. So I think it's that group beyond BRCA that we can really extend the benefit of PARP inhibitors and immune therapy.
Thank you.
So I'm certainly going to mention screening, but I think that goes hand in hand with something called risk prediction, which is working out who's actually at risk of getting ovarian cancer. We only know a fraction of the real reasons as to why people get ovarian cancer, and I think we need a better way of working out who's at risk other than what I would consider relatively blunt tools like a BRCA test, because that only accounts for a small fraction of the women that get ovarian cancer. Probably 90% of women who get ovarian cancer, it's not down to a single genetic defect. And if we could work out in advance who's at risk, then we could work out whom to target different interventions to. And those interventions would be, for most women, complete reassurance. You don't have to do anything because your risk is very low. For women with BRCA mutations and other genes that have a very high risk of cancer, the answer is to have risk-reducing surgery, to have the organs at risk removed. And then there'll be a middle group who are at an intermediate risk, and they may not feel their risk is high enough to justify having their tubes and ovaries removed. And the consequences that come from that, which I'll talk to later this afternoon. But you could potentially offer those women a screening test if you had a screening test that was effective. So I think a combination of risk prediction with screening is the thing that would have the greatest impact on ovarian cancer mortality.
Thank you.
So I'm going to echo what Yvette and Adam have said in terms of screening and earlier diagnosis for ovarian cancer. But just to add something to that, I think we need large studies to do this, and we need collections of samples that we can look at a number of different tests in combination. I don't think we're going to find a single test that is going to be the answer for screening in ovarian cancer. So I think it's really important that when we're going forward looking at future studies and trials that we are collecting blood samples and other samples so that we can investigate a number of different tests and work out the best combination for earlier detection and hopefully in the future screening for ovarian cancer.
Okay, so thanks for putting me last, which means that everybody's coming up with the good ideas. I was thinking about this a little bit this morning, and it's sort of been reinforced by talking to various people this morning and over lunch. And unlike Adam, I read the question, which says it's for women with ovarian cancer. So I'm going to avoid the risk prediction, but I think that is really important. I just begin to think that as we start to develop new treatments and new ways of subclassifying the disease, 20 years ago, ovarian cancer was one thing. Now it's at least 10 different things. I think it's going to be 20 or 30 different things as we divide it into ever smaller groups based on the biology of the tumour. And we've got lots of different treatments, be that surgery, be it chemotherapy, be it targeted therapies. I think the biggest challenge we face is how to put all of that lot back together again to develop an individualised treatment plan for each patient, starting right at the beginning based on the biology and beginning to understand which treatments we put in which order and maybe tearing up our current rule book and designing new ones. And I think the challenge within that, and maybe where the research has to come, is how do we deliver that care in a seamless fashion? There have been so many comments today about knowledge and information and how do you get that in a pertinent, timely manner? And how do we make the patient journey through what's going to become an ever increasingly tangled web clearer and easier for them and their clinicians to navigate? So I know it's not quite a research question, but I think it's probably the big challenge that I can see us facing over the next 10 years. It's a good position to be in, because I'd far rather be here with lots of treatments to talk about than where we used to be with nothing to talk about, but I think it brings its own set of problems. So that's my answer.
Fantastic. Can I open that up? Any comments from the room?
Yeah, I hope they wouldn't make that stance. I think if there's another treatment that's going to be useful, I hope they'll look at that. So I'm not too worried about that one, but I take your point exactly, and I think we absolutely need to do a bit more slicing and dicing of the disease into its subgroups. I know that makes things more complicated, but by and large, those current groupings or the ones we're developing will be based on the intrinsic biology, not what it looks like to me as a surgeon, not what it actually presents like on a scan, but what the biology of the tumour is doing. And I think we're getting better ways of doing that now. And as we do that, then the treatments will necessarily map onto those particular subtypes. Most of us treat endometrial cancer, and actually that's a disease where we're making quicker progress, and we now have a fairly clear classification of those tumours based on their underlying molecular biology. What's the biology of the tumour? And we're then beginning to start to think how we might treat those differently. We're a little bit behind the curve in ovary because it's a more complicated disease, but I think that's where we'll go. Absolutely, we need to change the names. Sorry, you're going to have to change all your branding, but best of luck with that.
And I think one thing I was talking about this morning was the leaps and bounds that we've seen in other cancers is because we've nailed down on subtypes of those cancers. So the benefits and things that come in lung cancer are not just for lung cancer patients. They are for specific lung cancer patients that have specific things on their lung cancer. So as Richard was saying, the BRCA part thing is the first time we've done that in ovarian cancer. And I know we now confusingly have access to all high-grade serous ovarian cancer patients, but the benefit is still greatest in the BRCA patients. So when we try and do that in other cancers, we've been successful. I think in terms of looking at the cancer and naming it, last year or the year before, the FDA approved a drug called pembrolizumab, and it was the first drug that was approved not specifically for any cancer, but for a cancer that has this thing called microsatellite instability, which unfortunately isn't a big thing in ovarian cancer. But if you have the kind of cancer that has that, and it could be any cancer type, commonly it's endometrial cancer or bowel cancer, then you could potentially access a drug because of what's wrong with the cancer, not what the cancer's called. So I think as researchers, we are already doing that. But it does get quite confusing because the problem with ovarian cancer, we also have the fallopian tube primary peritoneal situation. And I've had patients say, has my cancer changed? Because the surgeons told me it was primary peritoneal and I'm calling it ovarian cancer. So I think we've not been that good at explaining these things.
My oncologist always writes, sorry. Sorry. My surgeon always wrote on my notes and on my letters primary peritoneal cancer. My oncologist always writes ovarian cancer. I don't know.
They're probably, but they're both wrong. Because it probably starts at the end of the fallopian tube, but it's a name. It's a name. The disease, at least you know what type it is, and it should therefore, that at least gets you onto a better footing with people knowing what kind of cancer it is and what drugs it's likely to be responsive to. But all the current evidence is that high-grade serous cancer, which I presume from what you said is what you may have, that almost certainly does start off in the fallopian tube. But in most patients, by the time it's diagnosed clinically, there's a lot of disease there, and it's very difficult for a pathologist to say where it actually started.
Thank you.
The new classification is that if it's in the fallopian tubes, then it's called fallopian tube cancer, regardless of whether it's in the ovary or the endometrium or the peritoneum. So there has been a reclassification, but we're quite slow to catch on, and we kind of use the nomenclature, ovarian cancer for everything, to catch all.
High-grade serous carcinoma of tuber ovarian origin. In my letters. See, that's a bit of a mouthful.
Yeah.
And secretaries hate me.
Marguerite.
Thank you. I had a hysterectomy about 30 years ago because I had endometriosis, and they left my ovaries behind. But they're saying now if they do that now, you're in more risk of getting ovarian cancer, which obviously that's what I ended up getting. Is that right?
Right. Adam?
So you had a hysterectomy, they left your ovaries behind,
Yes,
and now you've been
because
told.
they said I would have gone into an early menopause, so they left them.
So there's very good evidence that early menopause is not a good thing, and you probably do more harm than good taking ovaries out premenopausally unless you really need to. But technically, many surgeons would have actually left your fallopian tubes at the same time as leaving your ovaries. It's a simple issue of where you put the clamp.
Yeah,
do
the
you put it down
fallopian
the side
tubes
of the
were
womb,
left.
or do you take the tube at the same time as taking the womb and leave the ovary behind? So many women in your position probably still have their fallopian tubes and therefore may be at risk of ovarian or high-grade serous tuber-ovarian cancer.
Yes.
But the background risk of that is under 1 in 50. So it's not a huge risk. I mean, the risk of all ovarian cancers in the general public in the UK is at most 1 in 50 if you don't fall into a high-risk group. High-grade serous cancer, about 70%? Epithelial tumours. So it's
Which
less than
mine
one,
was.
somewhere between 1 in 50 and 1 in 100. So it hasn't increased your risk, it's left you with a risk that you would have had anyway if you hadn't had a hysterectomy. I hope that reassures you and answers your question.
And another little question I'd like to ask. Both my granddaughters' grandmothers, myself and the other one, both have ovarian cancers. They're 9 and 11. What's the chances of them?
I'm going to be talking about genetics in the next lecture, so after Liz. So if you listen to that, and then if you have further questions, feel free to ask them afterwards.
Thank you.
Yeah?
Thank you. Lady over here.
Can I ask how much research is going into the risk factors associated with ovarian cancer? Because I understand people who started their periods early, people who didn't have children, people who have a late menopause were all at risk of ovarian cancer. Now, has that been proved or disproved from the research? And is there research going on in relationship to it?
Yeah, thank you. And I suppose, could you speak also to the magnitude of the risk relative to other factors?
So the answer is yes, those things can influence your risk of cancer, but that magnitude of that risk, as Anne mentions, is really fairly small. It's not like if you've never had kids, you're definitely going to get ovarian cancer, or if you've used the pill for 20 years, you're not guaranteed not to get ovarian cancer. These are all things that go into the mix, and this is what I was talking about earlier in terms of risk prediction. So what we really want to be able to do is incorporate lifestyle factors, reproductive factors into a single figure at the end, including your genetic makeup, including what's called epigenetics, which is how your genes are modified by your lifestyle and your environment. So we know that if you have used the pill for a number of years, that may cause modification to your DNA that affects your likelihood of developing certain cancers in the future. So there is a lot of research going on into this area. The epidemiology, as far as I'm concerned, for those major factors is done and dusted and proven. Now what's more interesting is to look at why are those factors protecting or increasing risks of cancer, and how can you use that information to work out an individual's risk and then classify them as being low, intermediate or high risk, and then do the right thing for them, or at least offer them the options that are appropriate to that level of risk. But I wouldn't want anyone in the audience to think either that I've never had kids, I'm going to get cancer, nor, I'm afraid, would I want them to think I've had lots of kids, I've been on the pill a long time, so I'm never going to get ovarian cancer, because we've all seen patients who have all the right protective factors, but for whatever reason, they still got ovarian cancer.
Lauren.
I had several failed IVFs in the late 80s, up to the mid-90s. I just wondered if that could be a factor.
Sorry, I'm really hogging the mic here. But, so there was a lot of earlier research to suggest that IVF, particularly if you didn't get pregnant after the IVF, might be linked to a high risk of ovarian cancer. The last thing I was aware of was actually a very large Danish, I think it was, study. And the great thing about Scandinavia is they have these amazing health registries where they know everything that's happened to you from birth to death, and they know exactly who's had operations and other hospital episodes. So they know what's gone on. And that data, which seemed to me to be better researched and more accurate and a better way of doing things than previous older studies, found that actually it was only the risk of borderline ovarian tumours that was increased. So I don't really feel that IVF is a significant risk factor for ovarian cancer. I try to be reassuring to people that have had IVF. I don't know if any of my colleagues would disagree with that.
No, I'd agree with that. I remember looking this up, and as Adam suggested, the original data was based on very small numbers, but it sort of scared the world because it was at the time when IVF was becoming more popular. So I think it was raised out of all proportion as a potential risk. But when you look at the much better studies that have been done since, you really struggle to see any effect at all from IVF. So I think we've pretty much discounted that one. Yeah.
Okay, in the front.
Talk about screening and early diagnosis, but talking to a lot of people online and here, everybody seems to be diagnosed at quite a late stage after repeated visits to the GPs. Are the GPs going to be having any more training for screening and testing for ovarian cancer?
Yeah, I think this is a really difficult issue. Target takes a lot of credit for actually the training that's gone on so far. So we're in, again, I've kept saying it today, but we're in a much better place than we used to be, and many more GPs are aware of it than used to be. The problem we face with ovarian cancer is that the symptomatology is slightly vague and it gets crossed over with lots of other things. That's not to say there aren't symptoms, because there usually are, and it's about recognising what they are, but it doesn't have a clear-cut symptom like coughing up blood, which most people recognise as abnormal and indicates for lung cancer. The other issue is the infrequency with which GPs see ovarian cancer cases compared to everything else. So I was horrified years ago when a GP stood up and said, as a GP, I will see a patient with ovarian cancer probably once every 10 years. So that's the diagnostic, it is the needle in the haystack that we're asking them to find. So I'm not saying there's a lot more that could be done, because there is, and we need to continue to raise that awareness and that symptomatology.
Because of the repeated, over 12 months, 18 months, even I've even heard 2.5 years.
Yeah, no, I
and they're going
agree.
back once a month with exactly the same
I
symptoms.
think the message that came out a couple of years ago was that irritable bowel syndrome is not a diagnosis you should make in over 50-year-olds. I think that's the sort of statement which is really powerful, because it gives GPs that trigger. I shouldn't be making this diagnosis. I should think of something else. And I think we have to think of clever ways of trying to do that, rather than just saying, think ovarian cancer, because it doesn't always hit their register, but thinking of other ways of turning that around. I think that's what will be effective.
My question follows completely on to that one, is we have, being breast aware, should we be abdominal aware? Because so many people I meet have had lumps in their abdomen and ascites. Neither of those two things are normal. So, if we can go to our GP and say, this is a specific lump, or, this we're showing that we've got ascites, whichever, those symptoms. So perhaps, I know that's not a clinical, that's an observational thing, but it's actually so relevant, and it follows on exactly.
So there is new guidance from NICE about the symptoms of ovarian cancer, and because they are so non-specific, that's right. A lot of women don't have. Yeah. So the GPs do know about the new guidance, and definitely within our service, the gynaecology surgeons that we've seen have had increasing referrals from general practice, and part of that is because there's a group of symptoms that you have over a month. If you have it consistently for a month, they're meant to do a CA125 and then refer in early, and there's sort of early pathways.
And I feel very passionately about this. I think, unless before we ever get to the clinical trial that makes it possible to cure, if I don't understand that I was as sick as one could be, and when they took me in January, they said at that point I was 4 stage B. It was everywhere in my body, and I had 60 appointments with GPs. And the question then becomes, where does the medical profession pick up these? I think my story is a little bit unique in that way. And where do these stories go? Because if the only thing I ever achieve before I die is that one woman who's my age, whose children, who's not going to lose them, because had I had a whisper, an insight, even I would have banged that surgery down to do every test. And I was told everything is normal. And I was rushed into hospital and told if I survive 72 hours, I'll be lucky. So where do those extremes go?
I'm sorry to hear that, and I'm sorry to say that's certainly not the time any of us have heard that type of story. It is a common. We hear it, and we get upset by it too. It frustrates us. There are some positive things going on. One, I'm sure you've heard recently that there's much more of a call now for discussing, for educating children about the symptoms of cancer, just putting it into the national curriculum, which I think is a step forward. Another thing is that people are looking at using software packages in GP practices to spot the fact that someone has turned up a certain number of times in a certain amount of time with these types of symptoms. So little things should ping up saying, think ovarian cancer. And I think as GP gets more, as general practice gets more fragmented, I think have all experienced, we don't have our own one doctor that looks after us from cradle to grave, unfortunately. You're lucky if you see the same GP twice in a short space of time, and that's not their fault, that's the system's fault. And the other thing is that there are some pilots now that are, I'm not yet aware that they publish their outcome, of a sort of a woolly symptoms clinic that GPs can have rapid access to, where people with vague abdominal symptoms can be sent in on a 2-week wait and seen by a variety of clinicians. So not just a gynaecologist, but a gastroenterologist, for example, as well. And they'll have rapid access to a CT scan in the hospital as well. And the idea is you just try and speed up that pathway. And I don't know if Liz is perhaps going to mention anything about that in your talk, or you are? Sorry. Okay, well, that's good. I'm not stealing your thunder. So people are well aware that early diagnosis in the UK is a real issue, not just with ovarian cancer, but with many cancer types. And that there is work going forward, not just on the research side, but on the NHS organisational side. And I think things will get better, but it's going to take a long time. It's going to take a long time. So
and yet I had a grade 3A serous carcinoma.
So when we talk about slicing and dicing these cancers into different types, there are clearly some types that just do not express CA125. So CA125 is just a protein, and it's made by the cancer cells, we believe, and pushed into the system, and you can then measure it in the blood. But there are some tumours that just don't make that for their own particular
So I went
reasons.
over 2.5 years like that before it was, and I actually suggested to my GP, do you think it could be?
Yeah.
And he said, no.
Yeah.
So I went longer, unfortunately, you know.
These stories, I'm afraid, we all accept it, are typical. We are, and that's where we need to do some work.
I think the other thing is that's difficult with the CA125, it's not just a cancer marker. So it can go up with your periods, it can go up with a water infection. It's not a cancer test. And I think the frustrating thing for you all is we hear these stories and we've seen you once you've diagnosed, so we can piece it all together and go, yes, classical symptoms. But the GP has 5 minutes to see you, and like you say, you might not see the same GP. So it is sort of putting the impetus, sadly, on you rather than sometimes the GPs to sort of collect these symptoms together and make those alerts. But I do think it will improve, like you say, with the initiatives that are happening. But the CA125 is a real bugbear that I have because it's not usually that useful for me in my practice. I don't rely on it to treat patients. I treat symptoms in patients and I treat their scans. And I think in diagnosis it can also be quite confusing as well. And if GPs are just randomly doing these blood tests without the reason to do them, it can actually cause sometimes distress and not actually the appropriate investigations for people.
Thank you. I'm afraid we're going to have to move on just now. There will be some time later for some more questions. Thank you very much to all of you. Yeah. Very good point, Steve. We all can do that as well. Thank you very much. So I think I'm going to hand over Richard to you now. Thank you to the panel.